a secure internet connection, a Wi-Fi network, and on a reliable device. And the third one is kindly mute your mic or audio and keep your video off if you can, if you're not presenting or commenting. And the last one, as you can see, there's a comment box on your screen. So please insert your comments and questions or inquiries to the comment box, if any, and vote or like to share the same questions with you. Thank you. Okay, next, I would like to invite Nick from Mainline to have a short introduction about the Chemsex Asia platform. Please, Nick.
Yes, thank you, Tumboy. Well, I'm first of all amazed to see that there are more than 72 participants right now in this webinar, and it says also something about the topic. So the ones who don't know me and Mainline, my name is Nick. I'm a regional manager Asia for Mainline. We work for the health and rights of people who use drugs in the Netherlands, but also internationally. And what we have seen the last years is the rise of crystal meth and also the rise of substances in a sexual setting among MSM, but also TG and LGBTQI populations. So in the Netherlands, we have started with developing interventions pre, during, and post partying, and to really improve the health of people engaging in chemsex. Internationally, we also saw the rise of, well, chemsex, but there was lack of, well, existing data, existing interventions, and also we feel that a lot of countries might face the same issues. And I think that the Asia Chemsex platform is a great way to bring together communities, activists, NGOs, organizations, or government organizations to really share information and knowledge and learn from each other. And that's why we also supported the Asia Chemsex platform together with the European Chemsex Forum, which is kind of a similar forum based in Europe, led by Ben Collins. He is here in the group as well, but also from Belani from the Global Fund. He's on holiday, but he is also really in favor to bring together a group of organizations to learn and share knowledge. So that is my small contribution. If you would like to know more about the Chemsex Asia platform, or if you would like to be more actively involved in developing and organizing these webinars, please let us know. So that's it. Good luck and hope you enjoy all.
Thank you, Nick, for this short and sweet introduction of the platform. And if you have anything, if you want to know anything more about the platform, please contact with us. Okay, let's move on to the boring part right now. Let's walk through the agenda. I hope that everyone already had a look at the agenda attached in your email invitation. So for the first webinar, we are focusing on the Chemsex data in Asia, what's there, what's not, and what's next, and how the data is utilized for advocacy and vice versa. After greetings and brief introduction from organizers, we're having a couple of excellent presentations of key findings of some prominent studies and research regarding chemsex in Asia as a region and in countries level, including Vietnam, Indonesia, and Taiwan. After that, a follow-up 10-minute Q&A session before we break out into small group discussions. We wrap things up after presenting the outcome of the 30-minute breakout session. So I hope everyone's on the same page about the webinar today.
I think the screen is black, Tung Bui. I think there seems to be a black screen in the presentation.
Okay.
Sorry for disrupting your great
And Tung, I think it's okay. So we now can move to the next parts of the webinar. So we can move to the presentation.
Okay, sorry, I'm in my mic. Okay, without further ado, let's start with the webinar by the first distinguished speaker, Pascal. His presentation provides an epidemiological overview of drug use in Asia among MSM. This regional study aims to help identify data gaps, stimulate its discussion on harmonizing data collection strategies and indicators. Pascal Tenway himself is a Canadian who has worked with people who use drugs to promote harm reduction and balanced drug policy for the last 16 years. So Pascal, please, I leave the stage for you.
Thank you, Tongbui. Before I start, I'd like to thank the platform working group for inviting me to do this presentation. I'd also like to thank all the participants who are here. I see there's a big crowd, so this is very interesting, and I'm very happy to see so many people interested in this topic. Before starting my presentation, just want to say that what I've tried to do here, what I'm trying to do with this presentation is to kind of give some kind of a background context. So I did a kind of a mapping of epidemiological realities in the region that relate to chemsex to kind of give us some background on which to start off from the same page. So my presentation, the objectives is really to review the existing data from Asia around chemsex to understand the scale and the scope of the issue in this region, and to hopefully help hone in and prioritize some of the target countries for additional research, as well as for implementing interventions to help people who participate in chemsex and who are at risk. So we also want to, with this presentation, I wanted to help kind of move our thinking forward in terms of data collection to ensure that we work across programs, academic institutions, and official government data to make sure that everything that we collect can contribute, giving us a better picture and a better understanding of the situation in the region and in each of the countries. So before moving on, just want to share the actual mapping that I have done with in the context of this project. So let me see if I can make this a bit bigger. So here, what I've done in this table is I'm presenting some of the information around MSM population size estimates on the left, moving on to the proportion and number of MSM who inject drugs, moving on to the proportion of MSM who use amphetamine type stimulants, and finally the numbers and proportion of MSM who are engaged in drug use in the context of sex. So I'm not going to go through line by line on this, and just wanted to show you that there is a lot of data available already. Most of it tends to be on towards the left-hand side of the screen, where we have MSM population size estimates that are fairly representative, that are being done through, the data comes from IBBS, from integrated behavioral studies. And as we move towards the right, we get more indicative data. So that means that the percentages are essentially numbers that come from small studies with MSM. So they might not be fully representative of the entire MSM community, but still gives us some kind of indication. So again, what I wanted to do is to give us a framework for which to understand the epidemiological reality of chemsex in the region and to put it in context, especially in terms of the data that we have available. So again, as you can see towards the right-hand side of the screen, we have very little data around MSM who use drugs in the context of sex. We have a little bit more data, but not a lot, around MSM who use amphetamine stimulants. And we have some growing data around MSM who inject drugs, whereas virtually every country in the region has a population size estimate for MSM in here. So I'll go back to my slides. Right. So as I said, more towards the population size estimates, we have very representative data, whereas for men who inject drugs, use amphetamine type stimulants, and use drugs in the context of sex, it's very indicative at this stage. It's mostly based on small scale studies. It's important that when we look at data, we understand also that not all drug use among MSM is going to be related to chemsex. So it's important to understand the patterns of use and which drugs are being used by MSM and other sexual minorities when we do data analysis. So for example, here I've listed some of the the drugs that are commonly associated with chemsex. Some of them show up in some studies, some of them don't. But generally, over doing a large desk review of documents, I've been able to kind of find that these are the drugs that come back regularly in terms of their involvement with sexual minorities, especially in the context of chemsex. At the last line, I put something about the recall period, and there's some challenges there in terms of harmonizing and comparability between different studies who collect data around different scope, a different time horizon. So some studies ask for lifetime drug use, some studies look at in the past 12 months or in the past month or at the last time someone used. This is one of the studies that was done in the region recently. In 2012, there was a large internet-based survey that was conducted through 40 community partners across 12 countries. The survey was disseminated online in 9 different languages, and it tracked the proportion of MSM who are using drugs and what kind of drugs they're using. And this table shows a differentiation between people who are living with HIV and those who are not living with HIV. As you can see, the column for drug use among people living with HIV is considerably higher than among HIV negative MSM. So this has important implications for programming. But again, this is just one study, significant number of participants, but still it's only one study and is therefore only indicative. Just some thoughts when I was going through the table with all the numbers that I've collected, and wanted to highlight specifically in terms of the overlap between injecting drug use and chemsex. And here I'm going to use the example of Thailand because I'm mostly familiar with the context and the programming in Thailand. So in Thailand, there's significant injecting but it's decreasing among the traditional people who inject drugs as intended in the HIV response. But when we talk about needles or about injecting, it's not clear sometimes whether we're talking about use of a needle syringe or a syringe only, in this case for booty bumps during chemsex. That data is not clear to what extent it's being tracked across the studies that focus on injecting among MSM who use drugs. Obviously, the data that I've shown also has some implications for programming. Again, I use the example for harm reduction here. So the population PWID size estimate in Thailand is about 70,000 based on the integrated biobehavioral studies that have been conducted in the country. But based on the data among MSM who inject drugs, we can identify up at minimum about 25,000 MSM who inject drugs. And those are injectors that are not necessarily included in the original 70,000 population size estimate for PWID, because those PWID and the MSM who inject drugs are part of very different social networks that might have not been reached during the data collection for the IDBS. So this has clear implications if the population size estimate is significantly higher, has implications for programming, for financing, and for planning. In this case, in Thailand, we've seen that there's a high proportion of MSM who engage in chemsex who are using mostly amphetamine type stimulants and other drugs, but very few are using opiates. And that means that the value of opioid substitution treatment programs is greatly reduced when targeting those populations, which means that the needle and syringe exchange programs for people who inject become all the more important, and the the selection of the needles, the gauges, the length of the needles, and the size of the needles and the barrels will matter in terms of ensuring that MSM who inject drugs have access to commodities that they can use and feel comfortable with. But also the data that I've shown has implications for other needs. So for example, I'll use the example of HIV in my presentation because it's a nifty entry point, but there's significant other issues that impinge and drive drug use and chemsex and risk behavior among MSM who inject drugs and who use drugs. So here I've listed, based on, again, the literature review that I've done, HIV is one component, but mental health, particularly depression, anxiety, and suicide among MSM, particularly those who use drugs, and their association with stigma, discrimination, bullying, harassment, and victimization is an important dimension that we need to keep in mind as we collect data and design our programs to respond to the needs of those populations. So again, it will be important to have data so that we can develop effective interventions that are designed to meet the special needs of MSM who use drugs, including those who participate in chemsex. We want to have differentiated packages of services to really address the needs of all the subgroups within MSM or the LGBT community who are using drugs, not only for in the context of chemsex, but certainly where there's most risk should be prioritized. We also want to make sure that as much as possible, we can come up with a consensus around the framework by which we can collect data to ensure that, that what we collect can be shared and compared and used strategically to develop effective programming. And what's clear also is that there are some significant gaps at this stage in terms of capacity in the region to address the issues of chemsex. There is a lot of capacity in terms of harm reduction for people who use drugs. There's a lot of capacity for delivering health services for the LGBT community in Asia. At the intersection of those two sectors, there's still some challenges in terms of cooperation and sharing and mutual support in developing programs to ensure that we meet the needs of LGBT who are using drugs, especially in the context of chemsex. So to close, I just have a few recommendations, which is essentially that we again come up with a consensus on a framework to collect data. And for example, the table that I've shared could be used as a starting point to create a living document that can be shared to keep information up to date and to keep track of the situation in the region. And ultimately, I think this platform and this exercise could be used to significantly facilitate and strengthen collaboration between the harm reduction service providers and the LGBT service providers to better meet the needs of sexual minorities who use drugs in this region. Thank you.
Thank you, Pascal, for this interesting presentation and your mindfulness of the time. If you have any question to Pascal, please insert your question into the comment box, and we're gonna have Pascal respond to the question later. Next, we have Ari from Indonesia. Ari has worked with HIV field, especially with MSM and trans, for the past 15 years. In 2016, 2018, Ari worked as program officer at APCOM. And now he's working as a coordinator of GWL INA, National Network of MSM and TG in Indonesia. Ari's presentation provides an overview data of drug substance use among gay men and other MSM in Indonesia. The presentation is designed to help identify the baseline data and also patterns of drug substance use and risk behaviors related to chemsex in Indonesia. Now I might leave the stage to Ari. Ari, please.
Hello, good afternoon, everyone. Thank you for this opportunity. I cannot share my screen. Is there someone who's sharing my presentation? Because I'm not co-host.
Yeah, I will say it now.
Okay. Nicotone, please. Set Ari as the co-host so we can share the screen. Okay. Please go on with your presentation.
Okay. Thank you very much for this opportunity. So we last year we having study on the use of drugs often in sexual setting among MSM in Indonesia. We are using the mixed method study. We are working together with PPH Atmajaya. It's the research institute in Indonesia, supported by AMPAC under the Bridging the Gap program. So next slide, please. Next, yeah. So the research background is we are seeing it's in globally like Chemsex has been reported from various places, and also the latest in 2017 and 18 that research has been done in UK that 22% of MSM reported having like involving in drugs in the last 3 months, and also the use of drug in sexual context is increasing the sexual libido, pleasure, and prolonged sexual activity, and also increasing the sexual trust and the ability to push sexual boundaries. And also we are seeing is that this requires the different handling compared to other drugs, because in example in different population, a different motivation, and also different frequencies. But unfortunately, an understanding of the situation Chemsex development among MSM in Indonesia is still unknown. That's why we're starting to do this study, because we want to know what are the situation in Indonesia. Next slide, please. So we are the location is all over Indonesia with the focus on areas where our members are located. Basically, we are using both of the methods. The first one is the qualitative. We are having the focus group discussion within our members to set up the questionnaires questions. And after that, we move going forward to quantitative approach. And the data collection method that we are using the referral network. Our initial target are 1,680 respondents. And we are using a descriptive analysis and bivariate correlation, and we are setting the inclusion criteria to identify as MSM, age 18 and over, live in Indonesia in the past 1 year, and also willing to be involved voluntarily. Next slide, please. So we are successfully gathered 2,290 total responses, but it's only for 1,412 who are completed the questionnaires. But after we are setting that I mentioned before about the inclusion criteria that we have managed, the final number is 1,281 respondents. Next, please. So this is the spread of the respondents coming. Actually, it's almost cover all the provinces in Indonesia. Next, please. So we are admitting that there are limitations of our study. First one is the findings cannot be generalized for the national level situation of the MSM who are using the Chemsex, because the most of the respondents coming from the Java Island, and also there are responses that fall outside this criteria is not included in the final analysis, and also there are no mechanism can be applied to ensure respondents are correct MSM, because since this is online based survey. Next, please. So this is the demography from the total 1,381. Mostly the majority is coming from 35 years above. Next slide. And this is the comparison between the using of drugs and non-using of using of Chemsex and non-using of Chemsex. So we can see it's like mostly are it's above 25 years old are mostly using the chemsex. Next. Next. So in general, our findings is in the context, when we are asking in the context of MSM relation status in the age category, the majority of respondents claim they don't have any partner at the time, and the motivation to use are varies, but mostly young MSM are much susceptible, forced to use by their sex partners. And also the popularity of psychotrops or substance is most common substance were used among MSM are poppers, and also the second one is sabu or ice or methamphetamine. And the feeling after using chemsex, the findings stated that not all drug use decisions are based on positive feelings, but mostly given sense of pleasure. And the source, friendship is one of supporting factors for getting the drugs or substance in the sexual context, except for getting poppers because mostly they can do it by themselves. Doing chemsex with anyone, the number of the different types of sex partners when the last chemsex show that the possibility of different types of ways. Next slide, please. So when we are talking about the proportion number of people at chemsex, the practice is most likely to be done during the sexual activity together or orgy or sextation with multiple partners. So when we're talking about when the last time you were using the substance or the drugs, the majority do it in the last 1 to 6 months. And do MSM, when we are asking about do MSM use chemsex because they lack of support, mostly the social support they receive is more or less similar between users and non-users. How far is the distribution of the chemsex practice among MSM? The more popular are among adult MSM. This is the question that we're talking about the using of the chemsex outside their reside city or reside country. When we are asking about how they feel about chemsex, the majority do not think negatively. Only a few feel the need to get rehabilitation due to drug or substance use. Mostly it's coming from the methamphetamine users. Next, please. So we are coming to the next section about the risk behavior related to chemsex. Next, please. So we can see this is the table of the last sex without condom. Mostly are the chemsex users mostly never use condom. So in total, that we can see the MSM who are responding this study, 41% are never using a condom. So it's quite surprising for us, especially when we are talking about in the past 15 years, we are working with the national program with HIV. Turns out this is the result. Next, please. So when we're talking about the condom consistency, there is no significant difference between the consistency of condom use, what with steady or non-steady or casual partners in the context of chemsex use. But in general, almost half of MSM experience depression and anxiety to different degrees without any connection to the chemsex practice. So the respondents are stated there are no relating between their depression and anxiety with the chemsex use. The frequency of sex among MSM was not affected by the decision to do have fun, but however, the chemsex practices are likely to improve the number of sex partners and also significantly influence sexual transition with a relatively high frequency of sex, especially in MSM age above 35 years old.
Sorry, Ari,
So
please wrap up.
Yeah.
You have 2 minutes.
Okay.
Thank you.
Okay. Yeah, it's almost done. So the chemsex users tended to meet the sex partners online and offline. The chemsex users had significantly more history of having STI compared to non-users of chemsex. Next, please. Yeah, next. Yeah, next one. The last one. This is one. Yeah. So no, the recommendation. Okay. So we have for the recommendation that we are proposed to our national program. The first one is develop a strategy to disseminate these study findings, and then second one to advocate for the incorporation of sexual drug use issue to Ministry of Health, to integrate to the IBBS, and to conduct regular periodic surveys among MSM, and the last one to conduct further studies on chemsex, and which has been put it on our the next funding request in the Global Fund on the period 2021 to 2023. Thank you.
Okay, thank you, Ari. That's very interesting. The next speaker is no stranger, Mr. Đoàn Thanh Tùng from Vietnam. He's currently the director of Lighthouse Social Enterprise, a youth-led organization working towards the future of health and equity of all young key populations. Tung has more than 10 years experience working as a young HIV activist and researcher in the field of stigma discrimination, rights, HIHR, and HIV and AIDS. Tung will present key findings of the chemsex study in Vietnam. The presentation provides a look into chemsex community in Vietnam, their social and sexual behaviors, risks, and barriers they face in accessing to harm reduction and HIV services. Tung, please take the stage. Thank you.
Thank you very much. Hi, everyone. It's Tung again. So first of all, I want to celebrate the International Youth Day and for young key population as well. And I really want to thank to the COC Netherlands to support us to do this study in Vietnam, and also Lighthouse Research Team. So I want to start my presentation by sharing with you some of the languages regarding the chemsex or Hai-Fan community in Vietnam. So you can see here, that is the all languages and terminology that we collect from the respondent to our study. In here, I want to highlight that there are very different languages that people are using to interact with other people among the chemsex community in Vietnam. So we also separate the languages for the northerns and also for the southerns of Vietnam, and it's really different. So that is the first I want to highlight. So for our chemsex study, we focus on 3 objectives. The first is describe the sexual activities in the context of chemsex, and also describe the situation of ATS use among the community, and also determine the needs of harm reduction among the chemsex community. We use the mixed methods for this study. So we have, in total, we have nearly 300 people respond to this study. In quantitative survey, we have 269 respondents, and qualitative, we have 24 in-depth interview with chemsex community in Hanoi and Ho Chi Minh City, two biggest city in Vietnam. So recruitment from the August of 2019 until October 2019. And you also can see in the screen some inclusion criteria of our respondent to the study. About the demographic characteristic, so most of the respondents are quite young. The average age is around 24 years old, and 25% of them migrant from other smaller province to Hanoi or Ho Chi Minh City. They also have the high education, with 65% of them with bachelor degree, and 29% of them with income less than 5 million Vietnam dong per month. The first finding is focused on the healthcare visit. So you also can see 8% of them self-report that they are living with HIV. And we also found that more than 20% of them never been tested for HIV. And it's very interesting to see in the number of people who are using PrEP, it's very low percentage of people who are on PrEP. So only more than 30% of them are on PrEP, because you know that PrEP is really important among and very effective preventions among the chemsex community. But you can see here only more than 30% of them are on PrEP. And also very low number of people who have been tested for STI, hepatitis C or B. About the reasons of why people engage in chemsec, the majority of them self-report that the chemsec help them increase the pleasure when they're having sex. And some of them also increase the arousal and enhance the confidence when they're performing new sex behavior. And some of them also enhance the confidence in self or body or sexual organs. We also ask the people or the respondents about the exchange money behavior. So you also can see the high percentage of them also engage in exchange money or present in the last 3 months. And the next slide is about the source of sexual partners in chemsec. It's also really good for us in setup and design the outreach programs. So you can see a very high percentage of them are finding sex partner through the dating apps like Grindr, Jack, or Blue. And a lot of them also find the sex partner or interact with chemsec communities through the social media like Facebook or Zalo. So I really want to highlight Zalo because it's really high number of our respondents. We recruit them from the Zalo because they have the different group in there to express themselves and to find the sex partner. And it's also really interesting to see that 35% of them has at least 2 sexual partners per one chemsec section. And more than 30% of them know nothing about the HIV and STI status of the sex partner. And also in their perspectives, when the first time they hear about the chemsec or high fun, they say that high fun, in their definition, that high fun is a relationship among many people, but not between 2 people. It means that they think that when they engage in high fun, it's not only between 2 people, but they supposed to have the sex with a group of people. And it's also really interesting that they have never met someone for many times. So it's mostly like they meet other ones. So also in the next data, so we also found about the type of substance use in the chemsec among the community in Vietnam. So crystal meth is still the highest the substance that people use during the chemsec. So 62% of them self-reported that they use crystal meth, and ecstasy is around 37%. And popper and alcohol are 2 popular substances that people use together with the ATS. And also highlight that in Vietnam, it's really easy to get the substance or ATS or drugs. People very easy to find it or buy it in most of the provinces in Vietnam. And their knowledge and also information about the drugs and how to use safe drugs and measure amounts of the drug when they use is also very low and poor. And about the condom and lubricant use, you can see here is always very low percentage of people always using condom and lubricants when they engage in chemsec. And I also want to emphasize that some of them reported they don't use the safe sex methods because their partners tell them that they are on PrEP. So they feel more confident to not using PrEP.
And they method, but no longer using talking about PrEP.
Yeah. And about the safe sex activities, and you also can see here the safe sex activities, it's only 21% of them say that they have the high safe sex activities, and very high percentage at medium safe sex activities when they engage in chemsec. I want to go to the next slide about the experiences of the health service. So very low percentage of people who access to the psychological counseling or treatment, and also treatment for substance use. Only 9% or 13% of them reported that they have experiences of access these kind of services. And also about experiences of stigma and discrimination from healthcare provider because they engage in chemsec. So you can see the highlight number here that people have been judged by healthcare provider because they engage in chemsec. And also they have been lectured by healthcare provider because they engage in chemsex also. And a few of them also reported that they've been rejected by healthcare provider because they engage in chemsex. So eliminate the stigma and discrimination from the healthcare provider and in healthcare setting also really important. We create these kinds of the table of the barrier of access in harm reduction services among the chemsex community in Vietnam in different levels of the barriers. The first one is personal level. So lack of knowledge, self-stigmatized, fear or disclosure, substance dependency, and mental health problems is main barrier for them in personal level. In the community level, we see the stigma towards chemsex engagement among the MSM community itself, and also from the society as well. And also
sorry, you have 2 minutes to wrap up. Thank you.
Yeah, and also the power in sexual relationship. In terms of the service barriers, it's limited information about the services, especially for the harm reduction services and also the mental health services. And inappropriate time schedule, lack of the services they need, and stigma from the healthcare provider is the main barrier. And in structural level, stigma towards substance use and also stigma based on the social and sexual behavior towards the MSM community. And in terms of the policy, the substance use is still prohibited in Vietnam or criminalized in Vietnam. We also developed a recommendation of harm reduction intervention from the chemsex community, and it take out from the survey and also from our qualitative interview. So first, we divide to 3 levels. The first, education, communication, and awareness raising. So people need to access the more accurate information on drugs effect, harm reduction, sexual health, and HIV and AIDS. Organize the personal or community-based organization events, offline event in hotspot, outreach, and provide information through the peer networks, and provide the assessment tool of substance use, substance independence, mental health issues, and substance addiction screening. In terms of the service provision, the community need provide counseling services, motivational interview, appropriate harm reduction package and service, and refer to HIV treatment and prevention services, and also provide the referral services to other essential services like registration, mental health, sexual violence, retention, and also other services. They need conduct more. We need to conduct more research on chemsex community and their issues and needs. Reduce the chemsex related stigma and discrimination. Implement the policy advocacy activities to decriminalization, and provide the training for peers, CBO, and healthcare provider on harm reduction intervention and support for chemsex community. And lastly, establish chemsex-friendly healthcare facility. So that is the whole findings from our chemsex study. If you have any question, please put it in the chat box. Thank you very much for listening.
Thank you, Tung, for the informative presentation. Just a small note to everyone. All presentations today are being recorded and all the presentations are available for sharing. So please fill your information and your email in the link that I sent a while ago in the comment box for further updates and subscription of our activities. Okay, last but definitely not least, we have Dr. Stephen Koo from Taiwan. Dr. Stephen Wei-Wen Koo completed his medical degree at National Taiwan University in 2008, and then in 2013, he had his internal medicine and infectious diseases specialist training at Taipei Veterans General Hospital. He's currently working as the director of Division of Infectious Diseases at Taipei City Hospital Renai Branch, and clinical researcher at Treat Asia Network in Taipei Veterans General Hospital. So I will leave the stage to Dr. Stephen. Dr. Stephen, please.
Good afternoon, good morning, everybody. I would like to thank the organizer for inviting me to share our experience in Taiwan, and also our previous experience with the Asia Pacific Chemsex Symposium. It's great to see a lot of old friends and new friends in this webinar. So my topic is, Chemsex Asia Pacific region and our Taiwan experience. So last year, we held our the first Asia Pacific Chemsex Symposium at Taoyuan. We are very honored to have a lot of researchers, including psychiatrists, ID doctors, epidemiologists, and also counselors, and also the first line workers on Chemsex to share their experience from different countries across our region. So from these data, we can find that actually chemsex is not that uncommon phenomenon in Asia, especially in our region. And the prevalence of chemsex among GBM-SAM is from 5 to 30%, depending on how you sample the population or who are you sampling. For example, in Taiwan, we had previously in 2017 PrEP online survey working with Hornet. So we found our the Hornet users, around 9% of them reported chemsex use in the past 3 months, which include use of MDMA, ecstasy, ketamine, GHB, GBL, crystal meth, and things. So, but if you are looking at people who are living with HIV among these participants, more than 30% of people reported chemsex. So the prevalence really differs according to the risk factors. So we also identify the factors associated with chemsex practice in the same survey. So people who are more age, that is age 26 to 40 compared to the age group below 25, are more chance to use to practice chemsex. And also people who are living in major cities, and also people with living with HIV, and people who practice chemsex also have more chance to have contact and no intercourse with me in the past 3 months, and also had any STI diagnosed in the past 12 months. Interestingly, those who practice chemsex are actually reported less happy about their own sexual life. So we really wanted to know what's the characteristics of the people who do chemsex in Taiwan. So we actually conduct another online survey called COMET study, which stands for Chemsex Online Survey for Men Who Have Sex with Men in Taiwan, in collaboration with Adam from La Trobe University and Dr. Carol and Jiawen from National Cheng Kung University in Taiwan. So this is a cross-sectional observational study, mostly including our participants online. I want to noted that it's not a prevalent study. So the study population is MSM who actually practice chemsex at least once in the preceding 12 months in Taiwan. So we really wanted to know how they feel and what's their thinking and how they practice this. We collected around 2,000 responses. Half of them were eligible for the analysis. So there's a lot of data in this study. So because of time strain, we can't really present everything to everybody today. So, but I would like to highlight several of the interesting and also important findings from the study. First is what the major substance use in this study. As you can see in Taiwan, crystal meth is definitely the most common used substance for chemsex. 2/3 of participants reported crystal meth use in the past 6 months, followed by nitrates or poppers, then ED drugs, and then GHB GBL. GHB GBL is actually more commonly used than MDMA. So it's becoming very important that we should include GHB GBL in the context of this. Polydrug use is quite often. More than half of people are using 2 to 4 kinds of drugs at the same time. This is the commonly combined substance use in Taiwan for chemsex. That is also crystal meth, GHB, GBL, ED drugs, and nitrates. So drug-drug interaction should be also addressed properly. We would like to know how people living with HIV were being treated, or how was the 1990 cascade looks like for people who practice chemsex. So 46% of people reported HIV positive status, and 90% of them were on ART, and 90% of those people on ART had a less undetectable viral load, so which is pretty compatible with the situation in general in Taiwan. For those who reported HIV negative status or unknown status, 15% of them reported PrEP use in the 12 months, and around 20% of people reported PrEP use in the past 3 months, whether they were taken daily or even drivenly. This is quite substantial, but I think it's not enough. We can still do a little bit more. Regarding the route of crystal meth use, most people inhale, but around 25% of the crystal meth users were actually doing slamming, so it's quite an alarming number. We also use SD severity of dependence scale to measure the dependence severity. So around 40% of crystal meth use actually had a SDS meth score greater than 4. So that means a dependence issue. So we try to identify other factors associated with crystal meth dependence in our study. So the users with less monthly income, say less than 50,000 NT dollars per month, or who actually had slimming, or who always feeling lonely, or who experience concerns from others, actually associated with crystal meth dependence. We also would like to address the issue of overdose. As you can see, more than more than 30% of the GHB, GBL, or crystal meth user experience overdose at least more than once. But very few of them actually sought for medical help, especially with GHB, GBL, as we know that GHB, GBL can be lethal. So this is something that we should address promptly. This is the last 2 slides. We also want to address the fact that for our participants, they don't like to seek for harm reduction help in traditional drug services like rehab centers or drug control and prevention centers. Rather, they prefer LGBT-specific organizations or HIV-specific organizations. So NGOs will play a very important platform providing harm reduction service for these clients. So this is the last slide. I think we have from our studies and from all the the speakers, we started to get to know a little bit about the chemsex situation in our region, but there's still a lot of left unknown. So important thing is that it's about time to let our skepticism and fear go, and we should walk hand in hand with our community bravely into the unknown. And thank you for listening.
Thank you, Stefan, for the amazing presentation. Let's move on to the Q&A question now. But before that, let me remind you guys that I just sent a link in the comment box. Please fill in your information for further updates and for the involve the presentation. I will share with you guys all the presentation today. Okay, as I can see from the comment box, Dr. Pascal already responded to some questions from the participants. So there's one question for Ari. Ari, you there?
Yes.
Okay, so one participant wanted to know that if there was any data of respondents on PrEP or able to access PrEP in Indonesia?
Yeah, actually, I already answered it through the chat, but yeah, yes, actually, we have the question about PrEP on our questionnaire, but since we are more focusing on the using of the drugs or substance and also the risk relating with the HIV and STI, so we are not concluded yet, and the other reason is because the program for PrEP has not been initiated yet by our government. So yeah. But we
Thank
have
you,
planned
Ari.
to, yeah, but we have planned to use those information to another study report.
Okay, thank you, Ari. As you can see the sharing screen, on the sharing screen, someone asked all the presenters, the speaker, the question of, because of legal sensitivities where drug users are criminalized, the outreach for MSM who engage in Chemsex needs a different approach. We are currently not funded by Global Fund or PEPFAR. How do we effectively advocate for funding or investments for work related to Chemsex? So any one of them want to answer this question? Stefan?
Yes. It's because actually MSM is not legal, it's not criminalized in Taiwan. So we didn't really have a legal issue, but we do experience like police are fishing on the internet to get our MSN like app users to and they had some like legal problem. So I think one important thing in the long run that each countries need to advocate for discriminalize or at least use a harm reduction way, and I don't want to say medicalize, but in Taiwan that the Ministry of Health has been pretty provocative in terms of substance problems. It's not, we started to see this as a medical issue, not a really a legal issue. So I think in the long run, people should advocate for these in this direction. But meanwhile, I think NGOs still play quite important to do that. I can't really comment on Global Fund and PEPFAR thing because a lot of the support in the NGO done in Taiwan were from the government though.
Thank you, Stefan. Pascal, from the regional point of view, do you want to add anything? Pascal, are you there?
Yes, sorry, I was looking for the unmute button. Sorry, yes. I think from my perspective, I completely agree that you know, outreach strategies for MSM who engage in chemsex needs to be tailored to that population. So it needs to be a different approach, certainly to other groups. In terms of the funding, I think there are some projects that are starting to show some evidence that of effective outreach strategies. I know, for example, of a project in Vietnam that was recently evaluated. I'm not sure if the evaluation report is available publicly, but certainly that report provides some basis to show that there's been effective outreach strategies piloted and developed under some projects. Those projects weren't necessarily funded by the Global Fund itself, but by donors who support the Global Fund strategies in those countries. So I think some of it, some evidence is available, and I think using that evidence would be the best strategy to convince the Global Fund to invest more. I think also that developing these kinds of platforms like the one we're all engaged in now is going to be an effective tool for convincing the Global Fund to invest a bit more. I think from PEPFAR and US government funding, there's always more challenges when when funding is requested for issues related to drug use. But certainly the Global Fund has a significant portfolio for this and should be probably the main target for funding advocacy in the coming period.
Thank you, Pascal. Tom, you want to add up anything?
Yeah, I just very quick add, as you know, Pat Palani from Global Fund is one of member of the working groups for Chemsex in Asia platform. So that is really good to inform him and also someone from the Global Fund. And I know that for participant of this webinar, we have a lot of the PEFA partners also joining us today. So I think this is really initial step to advocate for PEFA and Global Fund and also other organizations who are working for the community and also interested in the Chemsex community. And we definitely in next webinar will discuss about very specific interventions and also potential intervention harm reduction to share with people, so that also the more information for people to advocate with the people.
Okay, thank you. I think we close the Q&A now because we have the very important part coming up, the small group discussion. So now it's time for all of you to speak up and share your knowledge and skills and insight with us. We're gonna divide you guys into 7 small groups randomly, and each group, we're gonna have one facilitator who's gonna conduct the discussion. And there are 3 questions. Let me share the question. For everyone to discuss. The first one is, it's about data collection. What is there already? It can include community-based M&E, surveys, research, other data resources. The second is, what is missing? What kind of information and research regarding Chemsex is still missing that we need to advocate for, we need to do more in the future. And if we still have time, if anyone with information could share what are funding opportunities to collect data on Chemsex, or opportunities to collaborate regarding data collection on Chemsex. So we have about 20 minutes for discussion, for small group discussion, and then we go back to the bigger room for some summary from facilitator. So Nick, please.
Yes, I will now refer you back to the breakout rooms. You will get a notification when the time is up. There will be 6 groups right now instead of 7. And the facilitators are community experts from the field, have a lot of knowledge on doing research themselves. So please feel free to ask them whatever you want to. But for the rest, good luck and see you back in 25 minutes.
Thank you.
like in University of Los Angeles, UCLA also doing in Ho Chi Minh City, and also there's some research in Hanoi with Hanoi Medical City. So it's smaller scale, and the sampling is not representative for the whole country. So we cannot consider it's national data. It's sometimes it's like that's an estimate.
Definitely. Okay, we will go with the what is the missing. You also mentioned that you do not have any kind of data in the national level about the Chemsex, right?
Yeah.
So do you need to what kind of indicators we should focus on HIV mental health, and that's just like that? What kind of indicator we have to mention? We have to go with them. Can you elaborate it?
I think the data we need is more first about the we need the data on the population engaged in Chemsex. The data, first of all, who are they, the age, the first of all the education, the demographic feature, and also their behavior related to drug and drug use and sexual behavior. And also of course their access to the HIV services, and also we have some study on that.
Hello, I see that still some people are in the plenary session. I try to assign you to breakout rooms, but it apparently doesn't work out. Is that correct?
Interventions for MSM who are involved in Chemsex. So it is not from a scientific point of view, but more from the community point of view. What can we do for the community? What are the needs? And for that, I can focus on my own lived experience as well. What did I need at the time that I was participating in Chemsex? So what I would like to say is that if you have questions on interventions and things we are doing in the Netherlands, and we are also trying to create on an international basis, then you can always reach out to Mainline and ask questions on those points.
Oh, yes. So the intervention look like that to reduce the hand reductions, or what kind of intervention?
There are interventions for we do not only focus on problematic Chemsex, because as we know and as we've heard in all the presentations, lots of guys also see the added value of using substances.
I've seen papers coming from like Vietnam, Taiwan, Malaysia, a little bit from Singapore, but the rest there are not many research papers. I mean, like from other Southeast Asian countries. And even for those surveys that we have seen, They are more like the prevalence survey, like Stefan has mentioned. There are not many in-depth like studies on drug use, recreational drug use, or illicit drug use among MSM. So yeah, it depends on what kind of data you need also. If it's prevalent.
So I'm curious about it.
Okay, yeah. Thank you for sharing the questions and also the missing part of the Chemsex, the programs focused on Chemsex. So Greg.
How we reach or recruit a new group of people or new generation of people into the survey, into the studies is something that we need to focus on. Otherwise, the survey will be repetitively collect that data from the same group of people. Yeah, thank you. Who's next here? We have 15 minutes left.
Yeah, may I?
Yes, please, Eugen.
Firstly, apologize because for not being able to show the video because I'm on leave and I'm not in a professional environment. Firstly, I'd like to echo the first colleague who mentioned about the needs for more data about the transgender women group, because that is really underrepresented in the evidence that I personally have been able to use to access so far. In Vietnam, we I think it's more like
it's kind of like a normal thing to do, to use in terms of partying, recreational activities, and also hosting orgies or sexual activities in some certain places. But some of those are just coming from word of mouth, and there's no really information about it in a black and white form about on how much people are using chemsex nowadays here in the Philippines.
Yeah, okay. So very much, again, like similar to Pakistan, like a community understanding. You are able to draw that knowledge from the people that you work with, on the gay men that you work with, but it's more word of mouth, anecdotal evidence rather than hard data that you're able to use. Okay, that's useful. So you're on, Joy. You're on mute. So you're on mute.
Oh, it's Velo who's talking.
Actually, we are the organization who's working with advocacy of HIV and AIDS, and we do have the testing facility here for people, especially MSM people, who wanted to get tested for HIV, and sometimes through one-on-one counseling, we were able to talk about on some people opening about the use of drugs in their sexual activities. But again, it's really not that common all throughout the people who are coming here for testing. And those are the only times that we gather information about it. But then again, we don't have that firm data gathering about that scenario on drug use on their sexual activities. So,
and do you capture minimal.
Hi, Max, Kim, hi. I think you just joined the call. We are currently in breakout sessions. I can assign you to group 1, and so you can follow the breakout session.
MNE-based organizations. what do you want to? What is the missing? What kind of information?
I think the information that Vietnam has come up, it's similar what we are thinking, that if we have any survey or any activity or assessment, we think similar to yes, need the assessment, and we want to know about the how they access to the HIV service, and how they
I think you need to elaborate more about the information.
Or maybe we in Cambodia, as it is not popular, but maybe our IP or
seeing like some of my clients who use it on a monthly basis are using it weekly, and those who use it every 2 weeks are using it daily now, right? So so perhaps some kind of data collection on that would probably be of benefit as well. Yeah.
Yes, so that's interesting to hear. So shall we move to the next question? So that is a bit on the research background. So the question is, what kind of important information research regarding chemsex is still missing? So what kind of indicator that we should focus on, like syndemic factor, like including HIV, mental health, like other violence, etc. So what do you think?
You have 5 minutes, Min. Please, good luck, but only 5 minutes left.
Okay. Okay. Yeah.
Hi, I'm Nikki from APCOM regional network in Thailand.
Yes.
Want to work on it.
Besides Global Fund, we also have some funding from USAID.
Sorry,
but
from
USAID.
HID, right?
USAID.
USAID. Okay, actually, sorry, voice is a little. There.
Fast track some kind of interventions. Thanks.
I think that's a very, very important point, and I mean, if I can share my own feeling around this, is that I don't think that, I mean, when we were asked about what's missing, I was hoping not to hear that we want more data to document the problems, you know, but it's time now that we move forward to implement something, even though we don't have a really good data on what to implement. And so that's the part about how to strengthen what we already have had in the country through LGBT service providers who started to learn a bit more and more about substance use in chemsex is better than nothing. And in South-South collaboration, I think that's a wonderful idea. Thank you. Yin, please.
Yeah, we have 4 minutes left. Sorry, Dr. Nidaya, to interrupt.
Okay.
Good luck.
Thanks.
Component of those studies. So there should be some data. I believe most of their data is going to be about Thailand. So certainly that's on the first column. Can you scroll back up a little bit so that I can see the title for column 2?
Yeah, what is missing? Yeah.
Right. So what is missing, especially in a place like Thailand, is better coordination and cooperation among the civil society organizations, the donors, the government, and the academic institutions to make sure that as our colleague from IHRI was saying, that we develop interventions as rapidly as possible to meet the needs of people who participate in chemsex and other sexual minorities who use drugs. There's also a great lack of capacity, so I think having some technical support from abroad, having some capacity building for, and some sensitization effort.
Ground level. So we need a document which is in context with with Pakistan, or at least is in local language, so the community can understand what that chemsex is. For instance, the word chemsex is in English, so it is sometimes becomes difficult for the people or the MSM community, whether at or male sex workers, which are like unable to understand English or such things which we are trying to communicate to them.
Fantastic. Ali, that's like such a logical suggestion. We can do so much just by translating the findings of research and our existing resources into other languages. So if we're not able to do that research in Pakistan, for example, or we're struggling to do it in the Philippines, we do have data to inform the work from other countries. But if it's only in English, then lots of people just aren't going to be able to engage.
Southern Asian countries, are there any initiatives, any ideas that
there are more or less initiative, I would say, because people there, or the intervention there is focusing on, condoms, lubricants, and things like that.
Okay.
They are not focusing on the.
So HIV prevention for general MSM, not really like focusing on chemsex. Okay. Thank you.
Yeah.
I can see that in many countries there are not much data available. So what is missing?
Yeah, I have 1 minute left, Tungbui. Sorry to interrupt.
It bites me.
Sorry.
Okay. Thank you. Thank you. Welcome back, everyone.
Hi, welcome back.
I hope you guys have exciting discussion, small group discussion. And now it's time to report back as a summary of the group discussion that you guys have just conducted a while ago. So who volunteered to go first, please? Adam?
Sure, I will be quick. I think we outlined that there are a lot of gaps in data in many of the countries, particularly in Pakistan and the Philippines. The political climate there is such that it's very hard to collect data around drug use and around drug use among this population in particular. There are even challenges in collecting it within monitoring and evaluation data or clinical data. So we thought a lot about what's missing, and something we talked a bit about was the need to understand the experiences people are having in generic drug services. So there are lots of kind of, opiate drug, services set up for harm reduction and opiate use that many MSM might be accessing if they're experiencing a problem. So what experiences are they having in those services? Are they understanding of the needs of MSM? Do they understand the issues associated with chemsex? Are they being treated respectfully? So just wanting to understand what kinds of experiences are people having in different settings. And then where we can be collaborating, just one really good idea that came out from Pakistan was translating more of the research and the evidence and our resources into other languages. So there's lots of good quality data that's collected in some countries, and that could be of value in other countries where that data collection is more difficult. But a big barrier for it being used is it only existing in English, and that would be a relatively quick and relatively inexpensive intervention we could do quite quickly to collaborate and share our expertise. I'll leave it there so other people have a chance to speak.
Okay, thank you, Adam. Who's one that goes next? Yashi, please.
Yes, I will go. Yes. There are actually same almost issues with the Cambodia and other countries like Vietnam and other. Actually, people did not have such a lot of data in the countries and about the chemsex and MSM because there's a limited resources and but they are working with the small grants about the chemsex. Even in Pakistan, even but there's no any data in the Pakistan. But yes, they, if we go with the missing data, there is very small data is available, but there's not very bigger data with the small studies and data, which is not very proper data in the countries, even in the Pakistan, what they need. Where can we collaborate? But they need some special need assessment program to collect the data and work on it in the sport for the mental health issues and other issues. And some also want some Global Fund need to distribute some pipes and to use the for reduce the STDs and other things. That's all.
Okay, thank you. Amin?
So they need funding actually.
You said, okay, Min, sorry. Please unmute your mic.
Okay. Yeah, thank you. So according to our group, we noticed that most of the countries scarce data on the specific data on chemsex. And also Philippines also raised about their political issues because of the drug issue is prohibiting and lack of information. So it is an area we need to work more. And also from the other country, it's good to see that they have done, like Singapore, they have done online survey, but not in depth for the chemsex related survey. So they have planned to conduct the future survey focus on the chemsex and related with pleasures and also different groups on the target populations. And also it's good to know that VNN currently working on the interventions and the buffer to reduce the use of MED and linkage to HIV service. And also from Malaysia colleague, they suggested to look at the COVID pandemic effect on drug use nature, because due to the lockdown and it might increase the frequency of drug use during this period. And also regarding the what is missing, Cambodia colleagues also would like to explore about the economic impact and the chemsex. And it's not depend on their pleasure. They said we need to explore on the economic impact. And it's also good to know in the LGBT community, including bisexuals and lesbian, on their chemsex nature. And also the other colleagues recommend about the syndemic, to explore the syndemic factor, like including like mental health and also the and to make sure for the chemsex definitions is clear, because we have different chemsex definitions and we use different purpose for different study. So in future, what kind of chemsex definition we use is important for the to listen the community voice. So regarding the collaborations, chemsex is a public health issue as well, and also it can achieve the 1990 target. So it will be good if we can integrate in the HIV program. So from VNN, they also share the good practice, like they are integrating in the existing treatment program, like scaling up the OPA methadone program, and to address this chemsex issue. So also we know that SKPA project is working in the multi-country, and also they also look for the chemsex issues. So yes, this is my.
Thank you, Min. Thank you. That's very fruitful discussion. Ben, you want to just to provide an insight of what the group discussion of yours was?
I didn't know I was reporting back. I thought Natalia was reporting back.
Oh, okay. Yes, I am. I am. So hi everyone, I'm Nitya Panupak from the Institute of HIV Research and Innovation, or IHRI in Bangkok. Our group discussed quite a lot on what we feel is still missing data, missing information that we should focus on exploring more, as well as we also touch on some proposed collaborations and funding issue. So I will start with what we feel is still missing, and a few people both from the Philippines and Vietnam mentioned that we don't talk much about transgender women and transgender sex workers, as well as those sex workers. So this is probably related to the language problems, that we don't really have a unified definition of what chemsex means and which populations we are talking about when we discuss chemsex. And then the next thing is around the lack of qualitative data and how we could reach the new groups and new generations of people who use drugs in the region, so that we gain new information of what is actually happening in this generation of people who use drugs. And then we also discussed about stigma, and this is the stigma related to LGBT and stigma related to drug use, which are both very severe. And also we propose that any interventions that we can use now to start addressing these issues, such as the use of case story that could address stigma not only among clients but also among providers as well. And lastly is the more focus is needed to look at therapeutic responses to problematic chemsex, in which I think is probably related to some syndemic issues that the other groups have mentioned. And then that's the missing part. The collaborations part, I think it's very interesting. We discussed about the potential South-South collaboration, which can be used to start to implement any existing interventions, which is already existing in the region. That could be IEC materials, that could be service delivery models. And this is probably better conducted by local NGOs or CBOs in between countries rather than probably the regional body in the region. And then the second one is to strengthen harm reduction service providers and LGBT service providers collaborations. I think this could be part of the South-South collaboration that we can share lessons learned or experiences already gathered. And then we talk about probably regional advocacy efforts in terms of how we can use data collected to better get buy-in from a larger group of stakeholders. And lastly, we mentioned about, although we know that we don't want too many data to document the problems, we really need to move faster in terms of implementing interventions. But we can still use programs or projects to study relationships between chemsex and STI, HIV, hepatitis C, and sexual risk behaviors to draw attention from some funders. That's all we discussed. Yes.
Okay, thank you, Nataya. That's very interesting.
Perfect.
Stefan, in 1 minute, please help us sum up our discussion in our small group. Thank you.
Okay, I wasn't expected, but I think because like people are from different countries, so some countries just have a very preliminary prevalence studies, but some countries already had issue or like in-depth qualitative and quantitative study. I think a lot of like for people from the Philippines, they keep mentioning the policy issues and also the environment wasn't very friendly, especially to drug users. What's really lacking, I think, we don't really have MSM specific harm reduction programs for most of the countries, and also a lot of countries, the clean needles strategy were only based on PWID, but we should start it like intervention or harm reduction program like a more culturally appropriate way to MSM and also marginalized populations. Yeah.
Thank you, Stefan. I think we still have one more group left, right?
Yeah, it's from my group. So we have very diverse participants of the group. So from the Bangladesh, they have one study among the sexual minorities population focused on the math use and also sexual behavior. So they already have the 2 publications on sexual behavior. And in the future, they also will want to conduct a qualitative study in Bangladesh on interventions for the people who use meth and also other drugs. With proposed pilot intervention. In Thailand, Breakout from IHRI, they are an organization to support capacity training for community using different tools and also service provision tools to the community. From Indonesia, they're moving forward from the GWL study, and they're trying to incorporate the findings from the national data to the global funds new funding circle from 2021 to 2023. And in Thailand, there are several NGO offering the service for people using drugs. Many NGO focus on MSM using drugs, but in particular MSM injecting drugs. And also Mahidol University, they are conducting a study on MSM using drug in Thailand. And also in Vietnam, we have 2 new studies focused on campsite. First from the Life Centers and VHATTC from Ho Chi Minh Medical University. They are conducting an operational study on service provision and intervention to cancer community. So we definitely can learn something from them when they have any report. And one NGO, CSIP, they also collaborate with Lighthouse to conduct a new chemsex community cultures and characteristic in Vietnam. And I think we from the Asia Chemsex Platform, we are trying to develop a data hub to sell to people, and we're trying to collect the most of the data in the region, and we'll be shared with you later when it's finished. In terms of what is missing, so people also mentions about like most of the data focus on MSM using drugs, but we also need to focus also other key population using drug as well, like transgender people, so like with sex worker. We need more data on the effective intervention in the region. From the Taiwan, people also raise about the data on how we can help people use drug with harm reduction way, which is more effective. Also not only focus, data should not only focus on HIV, but also need to look into the mental health. And they found that there are really weak linkage between the mental health and chemsex. And we also need to look into the multi-issues faced by chemsex community beyond the HIV. And from the Indonesia, they also raised the issues of advocacy activity. It should not integrate in existing programs. And in Thailand, it's also lack of collaboration between the stakeholder with community to conduct the data collection and also research. We also need more capacity building programs for the peers and also for the existing programs, and also sensitization activity to address the stigma discrimination, target the people who use drugs. In Vietnam, we think that we still need more information and data on mental health and some of the other disease like hepatitis B and C among the people who use drugs. And we also need to have some data on law and policy and criminalization stated effect to the chemsex community in the region. And also the chemsex harm reduction services during the crisis, for example, like COVID-19. And the last columns about the area that we can collaboration. People also mentioned about the Global Fund and PEPFAR is to potential donor to integrate the chemsex intervention. But people also mentioned about the UNODC and also the other donor like Elton John. This could be potential donor for some harm reduction and also research activities. And we definitely can collect the data among the chemsex community from the community system that is really effective system to provide the services for the community. And lastly, how we can look at the experience across Asia. We can have the data hubs or something else to share with people, and campaigns on the chemsex community among the key population. Thank you.
Okay, thank you, Tom, for the very detailed summary. Nick, got something to say, right?
Yes. I've sneaked in some of the breakout rooms, and it's really interesting to see all the communities from the different countries coming together and sharing knowledge and expertise. Really, my compliments for all you here being here. I can hear from the different discussions there's a lack of, well, we need to have more knowledge and understanding of what are current harm reduction interventions related to chemsex, and how can we better create linkages with other key populations. So I think that is something really that we need to focus on the coming time, and it is also a link to the second webinar. So how can we learn from each other from existing interventions? Well, Mainline has done some interventions. We're supporting local organizations in strengthening their outreach and harm reduction interventions. Obviously, it's all context dependent, and all the materials, all the services you develop need to be tailored to the local context. But having said that, I think it's always great to hear from inspiring, innovative interventions from other countries. So yeah, please feel free to join the next webinar and well, keep each other updated about things going on in the countries and within the community in your working area. So really, my compliments.
Thank you, Nick. Thank you, Nick. Thank you, everyone, for participating in this very fruitful, informative webinar. As you can see, chemsex is an emerging issue, obviously, with growing concerns among MSM communities in Asia. But still, little has been known. and not much has been done to address this issue. So I think after this webinar, all of us have like a perspective into like what Chemsex is, what kind of data is still present, and what is missing, and what we have to do just to address these issues in Asia Pacific region. So before wrapping it up, I just want to remind people. Thank you, Nick, for informing people on the second webinar. Just soft reminder that the second webinar will be held on the last week of this month, August, in which we'll be looking at interventions targeting Chemsex in Asia, the existing effective models, what is still missing. So everyone is encouraged to participate, contribute, and work with us as participants, as speaker or presenter. And if you desire to engage yourself more with us, feel free to apply for a seat in a core working group as well. I already sent out a link, a Google link, for people to fill in their information to join with us as the Asian Chemsex platform. Please, I will send it again so people can actually access to it.
Yeah, in the meantime, I also want to add that I saw a lot of very good idea and also feedback from the people in the chat box. So please feel free to send us any your feedback or comments or any idea that you have after this webinar. I will show you the information of working groups, of Asia working groups, and just feel free to send us an email for anything else related to this webinar.
Yes, and of course, contact us if you might need anything. So all the contact details, emails are in your agenda, attached in the invitation email. Please contact us if anything. Now, thank you. Thank you for being here. Thank you for participating in this meeting. Stay safe, everyone, and goodbye.
Thank you, everyone.
Thank you so much.
Goodbye.
Bye-bye.
Bye.
Bye-bye.
Bye,
Bye,
Nick.
Nick.
Thank you.
Great job. Well done.
Thank you.